Good morning. This is the House Appropriations Committee. It is Wednesday, February 4th, 2026. It's about 9:45 in the morning. We're continuing to go through the FY27 budget, and we're delighted to have DEVA with us, the Department of Vermont Department of Vermont Health Access. That's the Vermont's at the middle, not at the beginning. So that's where I get confused. Anyway. Welcome. I know you've been here before, so I think we don't need to go around and introduce ourselves, but if you all want to introduce yourselves and your friends in the audience or on the screen, please go ahead.
Yeah. Good morning, everyone. I am Deshaun Groves. I'm the DEVA Commissioner.
Good morning. I'm Alicia Cooper. I'm the Director of Managed Care Operations for DEVA. Addie on the screen.
Hello, Addie Strumlow, Deputy Commissioner at DEVA.
And then we have a couple of
Alex McCracken, Director of Communications and State Affairs.
Great.
So it's me, Allison Novak, Financial Director in the Business Office.
Great. Welcome all of you. Thanks. Okay, so we have information online and on paper and on the screen.
and on the screen. Yeah. And so today I bring a whole crew of people. We are Stephanie Barrett-List. She retired 2 weeks ago. So
That's right.
it may be a phone a friend situation as we go along. But just wanted to give you an overview of what we're, the plan for this morning. Just a quick overview of DEVA and how the agency approached. I know the secretary was in here last week and approached how we did the budget process differently this year. So we'll go over that and then dive into our FY27 budget, both the admin and the program side, talk about our one-time ask, and if time allows, talk about some key accomplishments that we had over the past year.
And the key accomplishments are pretty important so they don't have to go last. I mean, the ups and downs do not need to be the first thing we talk about.
I think we'll have time. We're pretty sure we will have time to dive into those. The way that I planned it out, or the way that I think I
presenting it. Okay.
Yeah. So just to remind you, the agency this year approached the budget process in terms of the executive leadership team. So we thought about ourselves as instead of 6 different departments, as a kind of a committee of 6, thinking about the interdependencies of each department. And DEVA is one of those that sits there in that we have identified kind of key priorities. We looked at programs that were efficient, things that we were thinking about that may not be as the move forward, things that we needed to kind of accomplish in the near term. Our kind of 4 priorities this year were around housing, mental health and substance use, the healthcare in terms of affordability, quality, and sustainability, and then also the workforce that that works for us. It's very important there. So in DEVA particularly, we view our mission is to kind of improve. This is something that has not changed. Our mission and values haven't. What has changed though is being new in my role, I've taken the time to kind of listen and learn from different types of community partners and the agency themselves of where DEVA should go in the kind of the future. And what we have decided to do is move forward with what, instead of doing a whole new priorities, these are what I like to call priorities to refresh. We have 3 priorities around value-based payment, operations, and modernization, and really kind of thinking about how does DEVA think about the healthcare landscape and the role that we played there. Have identified 5 different priorities for the coming time. And that is really to champion our members and thinking about how our policies and programs really kind of how they become the center and how do we communicate those changes and how do we communicate in a more effective way there. Coverage. So the next one is promoting a high quality provider network. That means coverage is not enough. We need to have the providers in place. And so thinking about having adequate and appropriate rates, giving the providers the tools that they need to move things forward. The third is advancing population health and quality improvement, really kind of thinking and focusing on the quality of care that we give our patients and thinking about how we tie that into our provider network. The last two are more kind of internal facing priorities, really strengthening the operational infrastructure and system modernization. So thinking about the systems that we need to be successful to achieve those kind of the three mentioned priorities there. And then lastly, we can't do any of this without the people in our organization, in our department. And so we are looking at investing in now and how do we build our teams out and support morale there. DIVA really serves as in a unique role as you kind of think of that, the six departments, the Medicaid program runs through all six of them. DIVA acts as plays a dual role in terms of the Vermont healthcare. And so unlike most states, DIVA serves not as kind of the Medicaid program, but also the managed care plan. And in doing so, we have some core Medicaid functions covered under federal law around determining eligibility, compliance, state requirements, setting provider rates, managing benefits. And then at the same time, as we operate the health plan, paying for claims, managing provider networks, looking at advancing value-based payment models and monitoring the quality and outcomes. This kind of dual identity allows us to kind of more directly align financing and care delivery models in ways that other states may not be able to.
So I want to get back to the eligibility for a moment. What parts of Medicaid are you determining eligibility for? Because I think, doesn't DCF also do certain eligibility things? Or do you do all the eligibility for Medicaid across the agency?
Eddie, do you want to answer that?
Sure. I mean, in general, we're kind of the front door for Medicaid. So the initial application that someone would file to see if they're eligible for any programs comes in through DIVA. There are some exceptions to that I'm frankly not that familiar with over at DCF, but I think it's pretty small compared to, we're the general application processing entity for the state.
Okay, so when we go to 6-month determinations as opposed to 12 months, that's all landing in your shop?
Yeah. So and we'll talk a lot about that, but I know I've testified with you all before about all of those changes. Those are all in DIVA.
Yeah. Okay, great, thank you. Wayne, question?
Along the same lines, question. So the designated agencies or whatever the agencies are in the field, you heard something about with more paperwork requirements for Medicare than there are for Medicaid. Sometimes somebody may decide the wrong way and the providers and cause a liability that you might not be able to recover money from. What kind of controls do you have over that? And is that correct? Again.
I'm not sure I understand the question. What kind of controls we have under making sure that Medicare is paying their share or coordinating of benefits?
People eligible for it that are.
And how did they determine eligibility for the people who are applying?
Yes, and is it all done in your shop or is any of that eligibility determination happening at the level of the designated agencies or what are they calling them?
So how does the eligibility work if a designated agency is processing that?
Do DAs determine eligibility as well, or does it all come through you?
I don't think designated agencies have anything to do with that.
Yeah, I don't think so either.
Okay, mental health, substance abuse and development.
Right.
That's what our designated agency system does.
Right.
This is,
So that-
the eligibility is a state function. And those
Right.
are-
Right. Does that answer your question, Wayne?
You're on the right track, but I haven't got to the bottom of it yet.
Okay, let's keep going. Let's keep going.
So that kind of concludes like the overview of DIVA. And the next I was going to turn over to our budget recommendation. So in terms of salary and wages, it's really the ask is for 1.6 million for general fund, which will turn into a 1.35 gross. This reflects the impact of the Pay Act and the annualization of the 8 new positions in the VCCI program, which is handling justice reentry, and as well as some reclassification, some merit increases as well.
So we're not worried about the Pay Act. We are interested in new positions, and you'll get to that later on in the.
Yeah, we
So
will.
that's fine. Okay.
We'll get there too. And so just as five really quickly, this is vacancy savings, and that we're running a little just over 5% where we just budgeted for 3%. The next slide around our contracts, we are proposing that we discontinue the Vermont Legal Aid Medicare Advocacy Program contract. When we, in referencing the kind of the budget process that the agency took, we kind of looked at programs and contracts that looked at efficiency. And this is one of the things that we saw as one of the proposals, that we were spending more on the contract than we were recouping into Medicare in terms of getting back from Medicare. And so this is the reason why we have decided to kind of propose it, put this on the table as a proposal to cancel this contract.
Question on this. Yeah, go ahead, Dave. You start.
We heard from legal aid who said that, I think in November, they just signed a 5-year contract with you. So there's a little surprise in that a decision was made fairly long term. Was the performance that you just indicated, whereby you were spending more than what you were collecting in savings, was that for 1 year or was that for many years, several years?
So if you look back, if you go back to 2020, we've looked at it from 2024. Looking back at it, we saw that it was about a 60% return on the investment in 2024, about a 15% in 25. And then looking at this current year through to the end of December, we were looking at something around 46%.
Did anyone have an opportunity to lift the hood on the engine, so to speak, and try to determine why there was a decline and maybe make a decision to address what might improve the results? Or was the decision just we're not getting what we need, we have to move on?
I think that this is one of those instances where it's so challenging because we were engaging in the contracting process and anticipating that there would be a longer period of performance, while also going through that agency-wide process to review all potential savings opportunities across all of the departments in the agency. And across all of those departments, different options were put on the table, and the executive leadership recommended a set that felt that they would be potential to move forward. And so I think this is an area where we would certainly be open to continuing to understand those moving parts under the hood in this arrangement if the contract were to continue. If the proposal is to remove the contract from operating in the future, then that wouldn't be something that we would do.
And this proposal will cause the contract to cease to exist completely. So you'd have to do a complete rebuild should someone decide they want to look to see if there's more savings that can be achieved as there were in the past. I just want to make sure I'm understanding the situation. So, so in November, a decision was made, let's continue. And then under budget pressures, what can we come up with savings that was lost during that process?
Yes, that's correct.
Yeah, thank you.
I have to step away. I'll be back.
This sort of confuses me for a number of reasons, because you had to get your budget in by October 14th. So was this in the original budget, to eliminate it in the October, you had to turn into finance and management?
Yeah, so the budget process for the agency started well into May. And so this was always on the table. We just didn't know what was going to be kept into the final budget until.
So you had it in as a cut in your budget that you sent to finance and management, and yet you were signing a contract in November.
Yes.
That doesn't compute for me. That doesn't make sense to me. That why would you sign a contract in November if you had cut it out of the budget that you were sending to finance and management?
Because what we had done is we've put it into a proposal and we didn't know whether that would have been kept into the government's recommended proposal. And so
Did VLA know that it was being considered for being cut? Had you talked to them about this?
No.
And knowing that for the previous 2 years, you were not getting your return on investment and you went out to bid, I'm just wondering if there was anything in the RFP that talked about the need to get that return on investment. Did you change anything in the contract to help ensure that you were getting what you needed from it? Do you see what I'm trying to say? Because if it was a problem, then if you're going out to bid, you would want to change the contract to ensure that you were getting what you wanted, that your expectations were there. Was that in the contract?
So part of the contract did say that the state would notify the contractor if the monthly revenues totaled less than the amount invoiced during the 12-month period.
Was that in there every year?
And that would trigger a corrective action plan from the.
So was there any kind of corrective action that was done before the decision to cancel this? No.
Same line of thinking was.
Yeah.
In the contract. You let them know if something's falling short, but is there language in the contract that specifies corrective actions if such things happen?
Yeah, there was language.
But it wasn't implemented.
Correct.
All right. I have to think about all that. Let's continue.
Okay. The next item in our under contracts is our 2 chief medical officer support contracts. These are to help provide support for prior authorizations on mental health approvals within the for the department. The next section is around really IT system contracts. We have our Medicaid management information system, which is held by Gainwell, which has updates and maintenance. We've talked about this in our BAA. So this is just that. And then the next 2 is an increase in our call center for Maximus this year of 52,000 general fund, which equates to 150 gross. And then we are also proposing to end our HEDIS contract because we feel that the Medicaid data warehouse and analytical solution can now calculate those measures, which we no longer need that standalone contract. So that was just an area where the executive leadership team found a duplicity in trying to improve efficiencies there. Moving on, we have kind of the ADS health contracts. We have the Deloitte contract for the Medicaid data warehouse, which is just what we talked about in BAA. We're just now annualizing that for maintenance and operation for purposes, and that match will kind of, once it's certified, will go back in July. We have Oracle licenses, which have increased costs. We have those for technology purposes, and this is a 3-year kind of agreement, which we had to submit to CMS. And then lastly is our MMIS Gainwell contract at $60,000 for our general fund. I'll hold there if you have questions about those contracts, but.
I'm seeing any.
Okay. And
Dave, go ahead.
Well, I don't know if this is the right place, and if it isn't, push me to a different area. Do you have the capability to do with your management information systems some type of predictive analysis so that you can look at the total, all the beneficiaries, whatever, there's a big number of them, but, and are you able to say, you know, out of those 200,000, here's 15 to 20,000. That's what we're going to spend 80% of our spend on. Let's go in there and wrap them with services or whatever the best practice might be to help with a better quality of life and cost containment. Do we have that kind of capability?
I'm not sure if I would call it predictive analytics, but one of the things that the MDWES does have is kind of the creation of dashboards in which we can then kind of dive into the different populations and see
I
what
could
is
you said a
happening.
creation of what?
Dashboards.
Thank you.
And so that way we can kind of look at the different types of populations and see where they're using services, how much they're costing, and kind of do that deep dive to kind of better manage them in terms of population.
So it's it's not a criticism, but it's after the fact. These people are higher per member per month than others. And do you have contracts with independent entities or state employees who provide services to those high cost populations?
We have the BCCI, which does case management for some of those chronic care applications. And then there's the Blueprint and some programs that are ran out of the central office of the healthcare reform.
And is the BCCI where you're adding staff?
So BCCI last year or this year hired 8 new positions for justice reentry, and so where they can go into the jails now and help coordinate care before they are
Corrections and to do that. And does that VCCI pay for itself? It costs X. Does it generate Y in savings, or would we know?
I'm not sure if we ever looked at it that way.
Thank you.
Let's continue. I'll also just make note to welcome Representative Houghton from the Healthcare Committee. And if you have questions or anything, just let us know. Okay.
Perfect. And then for operating expenses, that's just net. And then we also have, as we discussed in the BAA, the new leases, which should be analyzed for those 7 months of $159,000. And I think last time we had a question of where or who we contracted with, and it's Malone Superior. It's where we have the lease agreements, but.
So you didn't go through BGS. Maybe this is the BGS.
Yes, that's a BGS question.
BGS did this. Okay.
Yeah.
And so this is the annualized version of the lease space?
Correct.
12 months? Okay.
Or for 7 months for this year.
7 months.
Isn't it 7? 12, hold on, sorry, yeah, 7.
FY 27
Yeah.
for 12.
Sure.
Yeah.
Moving again. And
No, that's sorry.
Okay, thank you.
And then to get after HR one kind of questions, we do see HR one kind of driving our significant changes for Medicaid eligibility. In terms of changing healthcare eligibility for immigrations, the more frequent recommendations in the community engagement or the work requirements. We estimate that we will need 12 new positions needed for the eligibility unit to meet that requirement, which will be reassigned from the position pool there.
I am wondering if you have considered, instead of a whole new group of employees that you would need to train, whether there are community partners that are already in contact with folks who could be doing some of this work.
Yeah, and I'll let Addie.
Sure. Yeah. Addie Stremolo for the record. I was in to talk with you all about these changes in depth. The community engagement, not in the sense of the work requirements, but in terms of leveraging community partners, is a huge part of this implementation. Under the Medicaid Act federally, only the state can do Medicaid eligibility. So we can't farm that particular function out in terms of actually processing someone's application or redetermination, but supporting people through that process, either through our sister program or general awareness in the community, again, is a big area of focus in the implementation, but not one that can replace the need for staff in our eligibility unit.
Well, does that mean that DEVA needs to sign off, but in terms of paperwork, putting the pieces together that would then enable a state worker to sign off on something, is that allowable under the federal rules?
Helping someone put together their application, yeah, absolutely. Sure. Signing the application has to happen either by the customer or an authorized representative, and
Sure.
then doing the determination, the eligibility determination based on that information has to happen by the state.
Okay,
Maybe they could do part of it. Send it to the
yeah,
state.
I just think that there are folks in the community, there's a network of organizations, that regularly work with all the same people. And could be, just as I know the Department of Labor has done this in the past, in terms of its own eligibility screenings, back in, my past, they've allowed providers to do some of that screening and eligibility work up front so that it is streamlined for the state. And just trying to figure out ways that we can streamline the effort, because I know that this is a heavy lift to make sure that people don't fall through the cracks. So.
Wayne? Oh, no, sorry, Dave was up first and then Wayne.
Just to augment Tip's questioning. Yeah, the area agencies on aging, for example, have a system whereby if I, as the senior citizen, want to, I could specify that Mike's going to get a notice when I get my notice. Because sometimes these things are confusing and it's hard for people to process them. But my buddy Mike down the street might say, hey, Dave, how you coming with that application? And so he becomes an assistor, not a brother or sister, but assistor. I digress. So if I'm at the child care center doing my child care application for the vet, and folks get help with that, that's a lengthy application. Expecting staff there to be able to say, hey, Mr. Iacoboni, your Medicaid is coming up in 6 weeks. Can I help you? And in the hope that the applications that are ultimately submitted to the state are clean or properly filled out and gives you a good return on things. Just that whole idea of investing in community providers to do that kind of work. Is that in this budget anywhere?
No, I don't think it is.
Would you if you could have, or is it
Did you
not?
think about it?
I think what we're looking at is the extreme amount of budget pressures that we had and did not come up with like new initiatives to kind of, or new ways to fund outreach, community outreach.
If I just one quick one, if you could, I don't expect you to have it now, but your staff that do the benefits determination, you could tell me what their ratio is, 300 to 1 client to worker, what they're processing now, and what you expect that to be with the new 6-month requirement. At one time, that number was as high as 1 to 600. There were many errors then, so I'm not suggesting we'll go that high, but just trying to see if there's some flexibility that might allow those 12 people to be deployed differently. Thank you.
Wayne, go
Would
ahead.
it be possible for me to just jump in briefly on that?
Yes, go ahead. Thanks, Abby.
I did want to, when we get to one times, you'll see that we do have an ask related to outreach and community engagement, along with this implementation. That is mostly for purposes of awareness in this, with all of the significant changes to the processes for this year. This figure is, ongoing need because we have projected what the increase in our workload is going to be in our eligibility unit due to these changes. And I know I talked to this committee about it before, but it's about a 30% increase. We do it by transaction now. It's not kind of like a caseload scenario as I think it may have used to have been. And just the sheer number of notices, new applications, new redeterminations that we'll have to do with these changes represents a 30% increase, which is why we need these 12 new positions, although they're not all eligibility workers. Some are for the noticing work, IT testing, and then also in our communications shop.
I think I have Wayne and then Marty.
Well, you've all heard my concerns about, tightness of operations and the possibility that feds could come and look at things and things, find things not so right. I know that the auditor's report, he was in here not long ago, and I think there were some audit findings along those lines. So it looks to me as if these 12 positions would help with those kinds of concerns. Is that correct?
Yeah, that's correct.
So I'm confused in why the positions, you're certainly putting them into the annualized budget, but why this extra expense of making extra notices is not built into the base as well, and you're using one-time appropriations instead.
So we are,
It's in the base.
go ahead, Addie.
No, this is in the base also, right? What's
Yeah.
in the next paragraph? Yeah.
Yeah, so in the next paragraph here, or in the next line, in the ups and downs, you do see an increase in the expected cost of $290,000 for outreach, for noticing for members. So it's doing outreach.
But it's the second sentence.
In the second sentence, you say you're gonna fund them with one-time appropriations and federal grants.
Oh, no, that's other system changes that need to happen.
Not this extra
That's a
notice.
little
that is-
Right. I apologize.
What
So
other,
what other things?
So I mean, a part of that is to change our systems in order to be able to kind of enroll, and Addie can go into more detail about that, but there are kind of IT changes to the systems that we will need to change in order to kind of do the 6 month and the additional work or the additional information. Yeah.
More frequently, that's something needs to be done.
Addie, would you like to add anything else there?
No, we can expand on it when we get to the one times, but that's all of the work we talked about again last time I was in that needs to be updated in our eligibility system.
The other additional item in our admin budget is the school-based services. We are moving to ensure Medicaid compliance. We're recommending that the school-based services program, inclusive of the administration, be restructured, consolidated, and supported within DEVA. And AOE retain the responsibility for the alignment of the educational policy. And so within that, we are asking for one new additional position in our business office to help us with that. And then as well as the kind of the school-based service EHR system and the random motion time systems will be implemented in October. Those startup costs are covered by a home and community-based service grant and then other grant funding. And this will also have to require additional maintenance beyond the resources. And then lastly, it's just payment and it's continued payments to the school districts.
so I think this may be a situation, you've talked about the language and statutory amendments. We may, if we decide to go this route, that we may just put the language in the budgets and instead of having to have a separate bill, so the money and the language all go together. We're working on that, so something to think about, have to understand it a little bit better first, but sometimes we just do that. Go ahead, Mike.
So AOE was doing this in the past.
Yes, that's correct.
So with the shift over, is that going to lighten the load over there? Any change in position to make up for that?
I believe that's the one, but that's the
So is that-
official. I believe so. Allison, is that?
Yes.
Okay.
AOE is coming in tomorrow, maybe? Today? You can ask them when
So
they
it shouldn't be a new position, it should be a transfer.
There might be, I don't know how they're looking at it. Yeah, we'll find out. Hold your question. So you're saying we're shifting this, but you regardless need one new position to do this.
Correct.
May I?
Yes, go ahead, Dave.
And why is this being done?
For Medicaid compliance
Okay,
on the federal side.
thank you.
And then our Medicaid policy staff can come in and talk more at.
Thank you.
And so the other thing, just explain the maintenance expense is a reduction in general fund, but an increase somewhere else. SBS IT systems.
Yeah, Allison, do you remember?
Yeah.
We can follow up. But
That would be great to understand what that is. Thank you.
And then moving on to more of our program side of things, what we have seen for trends and baseline. Some of these things have been, we have talked about it in our BA testimony, so the consensus and caseload. So we have seen on steadying of the caseload, but kind of an increase in those who kind of continue to remain. And so the recommendation is at 14.93 million in general fund. The other one, it's a buy-in. We are seeing an increase in the Fed rate. And also we are expecting a higher caseload for that population. And so we're asking for 0.702 general fund. And then the medic, and Dave, I saw your hand. Do you want to?
If I just.
Go ahead, Dave.
And refresh, is that the buy-in where people, Medicare, the dual eligibles?
Yes.
Used to be Quimby, Slimby, but it's not, and we did the Medicare program changes last year. And
Yes.
the cost related.
Yeah.
Thank you.
So there's actually two costs. So that one is around the caseload and the rate increase from the feds. And so that's the first one. And then the expand of the 150, where we expanded the expansion this year, that's you'll see that as the fourth line down here.
Thank you.
Oh, there's a question, Lord.
And I apologize, I'm jumping to the bottom, if that's okay.
Yep.
My question. My understanding from House Healthcare Committee is that there are ongoing conversations about that line item and how we can make it work. And so I'm curious why it's out of the budget for those conversations. Or maybe they have been and never been updated.
I think as we were putting together the budget and this recommendation, that this is something that we have proposed and that we have continued to have those conversations. But I think as language, and Alicia, correct me if I'm wrong, or kick me under the way that the budget language that we have now, we're not able to implement as needed. We can't draw down if the budget language requests that we do the enhanced match, and we cannot do that right now.
So are there no more conversations then happening about this? You're saying it cannot be done at all?
We can't, as it is written in the budget language, no, we can't implement, but we can continue to have those conversations of how to change that.
Okay, thank you.
So these numbers don't mean a lot to me because I don't have any sense of relativity. Are these up or down from last year? Is that, and what's the full amount? So the consensus caseload, what was it before? What is it now? So what's the difference? This is just a number. So it isn't, I'm not understanding it. And that's true for all of them going down. Do we have the before and after information?
For the consensus and caseload number, or all of it?
I don't know what it means because I don't know if it's,
Yeah, no. Let's continue to.
maybe we can find that somewhere.
Yeah, that'll be up in the spreadsheet on the ups and downs. So in section B307.
I see caseload and utilization, global commitment of 33,375,000. So that doesn't even tally with 35.48 million. There's some other.
Yeah, so what you're seeing is the total number. So the 14.93 and the gross of 35, you will see that those those numbers will add up once you look at section B307, where the cash load is 33.375. And then in section B309, for the Medicaid program thing only, we're seeing general fund of 4.29, 429,000. And section B 310, which is the non-waiver expenses.
Okay.
Those,
Okay,
we
so
just
you
kind
roll it all
of,
up
we all,
into-
yeah.
Into one, but is that an increase in caseload utilization, and what does it mean? Why is it increasing or decreasing or whatever it's?
Yeah, so that's an increase in caseload and utilization. Turn to my handy dandy binder here. Um, So on page 63 of the annual report, you see where we've identified each of the kind of Medicaid eligibility groups. And how we're seeing, whether we're seeing increases or in the expenditures and I can walk you through each of the megs, or we can,
I just want to understand what you're seeing,
yeah, so.
what the trends are, how it's comparing, what you're worried about, that kind of information.
So that section of caseload utilization does outline the change year over year, what we've had for actuals and our expected change with the narrative for each one of those. So it does talk about the individual Medicaid eligibility groups, and then it correlates to the downside of previous stage, and how that relates to the consensus numbers.
Can you just tell me? What are you seeing?
Yeah, so what we're seeing is we're seeing a steady amount of caseload, but what we're seeing is those who remain in the program are costing more. They have a higher PMPM, and which is driving up the increase in our expenditures.
So they're using the services more.
Yes.
And do you have any sense of why that's happening? We've been hearing that for the last couple of years, but I'm wondering what your thoughts are on why we have this increase in utilization.
I mean, there's a number of things. I think there's the increased pharmacy costs that we're seeing. We're seeing more people with chronic care issues. And so I think it depends. I don't think we have gotten really dove deep down yet of what are the drivers of the cost, but we're hearing it from other plans of like Blue Cross and others that, and with our other states too, is that we are seeing an increase in utilization and the increased costs, but no one has a good handle on why this is happening.
So are you planning to do a deeper dive to understand that better?
Yes.
Where exactly? Is it still wide, or is it certain parts of the state, or is it certain demographics?
I don't have that information. That's.
Yes.
To follow up on that, as part of the analysis that you do, is it possible that you can provide the data based on services providing coding or imaging, or so that we have specific categories of where we're seeing the increase, and then to try it over the last 3 years would be helpful. We want something that would satisfy that asking. And then
Sure, go ahead.
on the MSP, this is a program, Medicare Students Program, that is definitely going to help to the homeless. So is there any outreach that your office is doing, or AHS in general, to target the folks that benefit from this program?
Addie, do you want to take that?
I think that obviously a lot of notices have gone out for those who became newly eligible for the higher level programs. I think we're in discussions with the healthcare advocate about some additional outreach through, postcard or something that's a little bit more proactive for folks. But that's the extent of it that I'm aware of.
That's helpful, thank you.
Any other questions on that page?
If I may.
Dave, go right ahead.
And it could be in your big budget book here, but what would be helpful, and I'm sorry, I hope this doesn't add a lot of work, but if you had to explain these to 150 people with varying levels of understanding, it would be great if somebody could give us written at the sixth grade level so that I can understand. Just a little layperson's explanation,
Yeah,
couple of sentences. I know that's hard to do under each of these.
yeah, and that is actually in our budget buff.
Okay. And if somebody, okay, could just say
Yeah,
page 28. number
yeah, we
six,
could.
that would help us too.
Yep,
Thank you.
we could definitely do that.
Yes, Wayne.
Could you, talk to us a little bit about the clawback?
Clawback, yes. So the clawback is the Medicare Part D clawback that is set by the feds, in which they determine how much for Medicare for the state pays, and then the feds decide in their kind of formula how much the state owes in return. And so that's how for our dual eligible population.
So that, again, this is something that would be less clawback once you get those.
Yeah, we have no control over how much the feds determine. No other questions. Turning to kind of policy changes. We have one rate increase in our 27 ask. That is for the Northeastern Family Institute for their hospital diversion program. While NFI has received other provider rate increases, this is one of the things that as an agency, the program lives with the Department of Mental Health, but DIVA has the rate in our budget. And so when we came together as an executive leadership team, we felt that the hospital diversion program was one of the items to that needed an increase there, since they have not had an increase since 2021, I believe. The other kind of policy changes is we're recommending discontinuing the per diem rate for mental health extended stays in emergency departments effective July 1st. The rate was implemented in July 2022 as a temporary crisis response. And we have seen utilization since decline significantly. We have also sent this to the Clinical Utilization Review Board, which reviewed the policy and had also recommended discontinuing this, and it will have little impact to the hospital providers. The second item under policy changes is the dental incentive program. We recommend eliminating these incentive payments. These payments were intended to encourage private dental practices to accept Medicaid patients. However, there have been these modest payment amounts have not resulted in measurable increases in dental access. The third one is to increase prescription copays, and I think we can go into the next slide, Alex.
So, oh, you're gonna explain it.
Got it. So these are the with increase. This is a HR1 policy. Also requires cost sharing. So we are increasing the copays for $4 for preferred and $8 for non-preferred drugs. There are exemptions to the cost sharing and certain vulnerable groups such as children, pregnant women, and there is a limit of a 5% copay cap that is in place that protects those that remain.
That's an HR1 requirement?
To have cost sharing, it is, yes.
Okay, and then you're deciding what the amount should be.
Correct.
Yeah.
Can you tell us what the companies were?
It was, I think, one to three.
1 and 2.
One and three.
1, 2, 3.
1, 2, 3.
On Keo. No. Okay.
Okay, I think I had Wayne and then Marty.
No.
No, you're set. Okay, answered your question, Marty.
Well, I guess I'm confused. Are we paying an increased copay?
No, the beneficiaries will pay the increase.
Beneficiary, okay.
Yeah.
Yeah.
That was an increase becoming.
Nolan has a-
Nolan?
For the record, the line as well. So we have a 1, 2 copay. How is that not in compliance?
we felt that we needed to, we have not updated that for a while, and we decided the pharmacy unit recommended that we increase that to the new amount of 4K8.
But the reason I'm asking, you said you were required to do this under HR1. But I'm hearing you say you're choosing to do it. We already had 1, 2, and 3. So I'm trying to understand, was the increase because HR1 required us?
No,
Okay, so we were already in compliance with.
Right.
1, 2, and 3.
Correct.
Okay. And the proposal is to increase it to 4A.
correct.
Okay,
Which is a
that's different from
choice.
What I had heard earlier, that we're doing this to comply with HR1.
Right.
Just trying to clarify that that's not the case.
Yes. Okay.
If I
Thank-
may, the HR1 cost sharing requirements go into effect in 2028. So this is completely independent of that.
Okay.
Oh,
That's even more helpful. Thank you, I.
Is it, Madam
go
Chairman?
ahead, David.
So is it possible we increase them now, that we'll have to increase them again?
No.
Comply in 2028?
Unless the federal government changes the rules again, but
Never know, right?
that's where we are.
The second item is utilization management. This is really, as I began to talk, when I laid out the priorities of DIVA, it's look at our population health management and think about quality improvement. This is one of the things that the clinical units have put together and thought that they could have a decrease some of the consensus. And so we took in about a 2.3 reduction in the consensus number, thinking about how do we make the system more efficient and aligned with best clinical practices. And it's using and concentrating in areas of DME, special rate agreements, looking at different our coding review, and other items that we can use as terms of population health management.
So I will confess, I pretty much don't understand anything you said in that section. It feels like a lot of lingo that I just don't understand. I don't know what DME means either. So if you could.
DME is durable medical equipment.
Okay. So could you give examples of what you're talking about here or something so I can kind of understand what you really mean by this section?
Yeah, so for instance, for DME, it's kind of taking what we would do in pharmacy and where we have a preferred kind of drug list, making a preferred kind of DME list. So looking at what we can pay and what is needed. There's also thinking about prior authorizations of where we can use prior authorizations to reduce some of the unnecessary utilization.
Go ahead, Lori.
And
And then Dave.
I apologize, I don't have the budget book in front of me, so you might have more in there, but the last statement concerns me, considering in our policy committee, we've tried really hard to ensure that we are helping consumers have access to healthcare by limiting prior authorizations when it's not. So I'm curious, and it doesn't have to happen here, to understand that more and how the money equates to what you're saying, that the prior authorizations will be required.
Yeah, and then Laura, sorry, I misspoke. What I meant to say is to look beyond prior authorizations. What we have seen in the healthcare is like there has been a limit, like there were a reduction in PAs across the board because of access. But to look at other kind of population health management tools of how do we better manage our population. So like as Representative Yakuboni mentioned, can we do a deeper dive and look at concentrating case management or some other sort of services and direct it there? Or is there some sort of preferred list that we can refer them that's more cost effective than some other kind of device that may not be tested?
So that sounds fantastic, but it sounds like it's things that you haven't actually, a process that you haven't come to conclusion on yet. So I'm curious why the money is showing downward trend and we haven't done the analysis. Or maybe you haven't.
So the clinical units have done an analysis of like what they hope to. Nothing has been finalized yet.
It would be great to see that.
Dave?
Currently, my understanding is wheelchairs can be replaced once every 5 years. Will things like that change under this?
I don't think those will change. I think we might just see kind of, are there certain types of wheelchairs that we prefer or think the need? How do we better meet the needs of our patients better and using like our best practices and evidence base to do that.
So time there are wheelchairs, for instance, that to help people with positioning will move automatically and do things, uneven their legs. And that's best practice, I think, say
Yeah.
that we would continue those kind of things.
Yes.
Okay, I saw the word limits and I got concerned. Thank you.
Yeah, I'm a little worried about that too, Dave, because if you're saving money, it feels like it is going to be limiting choices and making things more generic that may not be in the best interest.
One size doesn't fit all
Yeah, yeah,
in this world.
okay. And then your base funding reduction?
And the base funding reduction, this lost my slide. The base funding reduction comes from that was 4.75 per member per month payment in the one care of the ACO. The ACO ended in December 31st, so we're not, those payments will no longer continue. And so that's what we're reducing our base because of that.
Like you don't have to pay.
Right, because there's no.
I can understand that one. Dave?
I just wanted to, my understanding is the ACO payments, some of them went out additionally to help primary care.
Mhm.
Now that the ACO is gone, will that kind of reimbursement stop or will it occur in some other way to primary care providers?
The additional dollars that One Care was directing to primary care providers was through the structure of their contract with Medicaid and their contract with those providers. Without our having the One Care arrangement, we do not have a separate mechanism for providing those additional payments to primary care at this time.
Do you know the amount of that reduction, the dollar amount? Could somebody get it for us?
We could follow up.
So is that can't be accommodated through some type of an add-on to commonly used CPT codes that primary care uses and inflate the current Medicaid rate by some type of fraction to make sure the dollars go through, or is it? I'm sure it's much more complicated than that, but
I think we could have a very long conversation about different ways that we could direct dollars to primary care. And I think that the ultimate policy question would be around the objective and whether or not it's to sort of mirror what One Care had been doing exactly or to do something different. And sort of depending on the goal, the tools might be different.
I don't, there is a down associated with this, I think, I can't find it right now.
Mhm.
I just would want to know if it were X millions of dollars, if we would want to put guardrails around that so that it doesn't go to a bottom line savings. Although I appreciate if it needs to make your budget work, you would tell us, but we would at least know what we wanted to fence off for some type of policy discussion by our healthcare committee, et cetera. Is that reasonable? Yeah, I understand. Yeah. Thank you.
Tiff and then Wayne.
This is not my budget area. So what I'm picking up on what, Rep. Iacoboni just said, are there other initiatives that, DIVA's pursuing to encourage primary care? And to bolster that particular, this is a down in this area. Are there ups or is there something built into the base to support primary care?
Not particularly with DIVA. There is the agency has the Rural Health Transformation Fund, which it significantly invests in primary care and looking at how do we kind of modernize Blueprint and other areas of the healthcare system. So there are kind of like thinking of more holistic, what do we do and how do we increase those costs or increase those payments through primary care through the Blueprint.
Wayne and then back to Dave.
So essentially, my question was going to be, does the new rural health transformation enter into this and does it perhaps perform the functions that the ACO might have
done or could have done. Or yeah.
Plan.
No, so the Rural Health Transformation Fund doesn't kind of supplant or kind of sub out what the ACO does. it kind of looks at the healthcare system in general, doesn't pay for, does not reimburse for things that we already have reimbursed for, already are doing, but looks at kind of like regionalization, paying for capital for kind of mobile units and developing the workforce, looking at kind of modernizing the different payments under the blueprint that can be used for primary care or kind of mental health or in other areas.
But the actual function in the field, wouldn't that be the same or?
And it does pay for some technology and data analytics that the ACO did do.
Ellen?
Can I just offer a very high level, maybe if you can explain it? Is that this is like a base funding change. The rural health transformation grants are a series of one-time initiatives. So that's the way you should think about it. One-time program initiative, think, well, this is the base fund thing. So this would not be real. Similar.
But
Right.
the intent seems to me, if they're one time, if using that one-time money works to set up a new system, then that carries forward in time, then it's, you can think of it as something that's more, not perpetual, but certainly more long-term and could address some of the base problems that we have. My thinking is, if we get this money, we might as well get the base bang for our buck out of it and set up things that are going to last through time that would go beyond the original base fund.
I totally agree. And so the idea of the Rural Health Transformation Fund is it's not just one time, it's for over 5 years. And therefore we're building out a system that can sustain itself and not just looking at one time, plug in and then look at 5 years, oh, we can't do it again.
There's a longer term look at it, but I'll remind the committee, we have no say over how the money is spent or, in the rural transformation grant. It's going to be a cooperative agreement with the federal government, and our only role is for the Joint Fiscal Committee to accept the grant. So we cannot redirect any of the money. We can't say, can you tweak this program? It's going to be what it is.
Is there any negotiation process with the state and the federal government?
That's been happening, and it's, I think it's done now. Not sure, but I think it's done because that's why we're accepting the grant on Friday. And so I think there were some, so we had something that Jill Mazza also presented to us in December. But that chart will need to be updated based on what their final negotiations are. So we will see that at some point, but I'll just keep reminding us and the viewing audience that we have no authority or ability to change anything in that agreement.
Thanks.
Dave.
Thank you. I promised our state auditor I would ask this question. I hope I get it right. He issued a report on Blueprint, and I think his finding, and somebody will correct me if I get it wrong, but he was just saying Blueprint doesn't indicate whether it's saving any money. And could you help us on that? Is the Blueprint saving money?
I think you would have to ask the Blueprint staff and central office for that.
If you could help me.
Yeah, I can help facilitate
With the
that.
contact info as to who I should ask, because it would seem to me the management of chronic care, all care for that matter, but chronic care is critical for cost savings and good outcomes, how we manage diabetes, et cetera, all of that. And I'm wondering if we're making the right investments in that area. I'm not trying to be critical of the Blueprint. I'm just trying to be inquisitive, just to know more. So maybe I could meet with them on my own, or maybe our healthcare committee will if we ask them to.
I bet they're on it.
To do that kind of a deep dive.
Yeah, and then if they're doing that, they can just let you know, or you can keep an eye out for their agenda.
Thank you.
So they can, you can go hang out there.
Place to hang out. Yeah, thank you.
Goodness, we have a healthcare committee. Okay, so I think we're done with questions on this page.
And now one-time funding. So this is the HR1 require system changes. The total changes for 27 are expected to be around 5 million. Just under 2 million of that is matched by the federal funds that were awarded to Vermont from which was passed in the HR one that offset some of those costs. We are right, if I can talk, we are expected remaining costs to be matched at 90%. And so and then also our specific outreach activity will also need to be funded. And we're hoping that 340,000 of the gross costs can be covered by the federal grant. And that's a question that we have with CMS. And if CMS cannot determine that the outreach, then we'll need a general fund for about 50% of that cost.
So what are the system changes about?
These are the three things that I've gone over with you all. There are three changes during 2026 that we need to make to
Okay.
update the way we do eligibility determinations for Medicaid,
Okay.
immigration changes, 6-month renewals, and work requirements.
So that all has an IT impact, is what you're saying?
Yes. Yep.
Okay, thank you.
Systems.
Okay, not seeing any questions. So Larry, go ahead.
Well, so I'm confused. Is this, the number we see on page 14? Does that number duplicate what we just talked about back on page 9?
No, these are additional. This is our one time. We
Oh,
saw.
This is one, this is the big one.
All right.
Gotcha. Okay.
Other questions?
No, let's go to this page.
All right, and then the next one-time request is for $2 million for the provider stabilization to help support providers who have demonstrated stabilization need and have a plan to sustain that. Just an update of where we are in our 27 provider stabilization. We have seen over a total of 28 applications that come in over the course of the year. We have 7 outstanding applications and have awarded about 8 of that for a total of 3.27. I will say that the budget requests or the ask from the remaining, the pending applications is around $12 million. And we have put out a alleged report on the provider stabilization fund of who's been applying, what they've been applying for. And that can be,
Is that what that link is down there?
that is what that link is down there.
Mike and then Dave.
Just get lost a little bit on this piece sometimes. So the provider stabilization, is there any relationship between that and extraordinary financial relief?
The two concepts are very similar. I think extraordinary financial relief is something that is explicitly available to nursing homes and private non-medical institutions. And we are able to pay those funds using Medicaid matchable dollars. This provider stabilization fund was a one-time appropriation last year that is making it possible for us to extend the same kind of financial support to other provider types, so non-nursing homes, non-PNMI providers, but this is all GF.
Oh, okay, got it. Thank you.
So this is all general, right?
Yeah.
Because we can't do Medicaid with this. So it looks like there's still a bunch in the works that are pending. I
Correct.
don't know the outcome of this at this point. Okay, Dave?
I think you just answered my question. So there's 12 million in need, and we're requesting to appropriate 2 million. But the 12 million in need is in FY 26, and that will go against the remaining funds of the initial 10 million,
Correct.
of which there's about 2 million left. Out of the
3.4.
how
About
much I could
3.4 million.
still left, so you folks will work your magic and do your best to try to accommodate people. So the 2 million for FY 27 is a best case estimate? Or is it, this is what we got left in the budget, we'll put 2 million up there?
Yeah, it was a governor recommended number.
Somebody gave it to you. I wonder if have the applications for help stopped? Have they slowed down, or are they still coming at a decent pace?
I would say that they have slowed down since
The initial,
the initial.
last application was received on January 12th. So.
Well, it's fairly recent.
Still coming in.
Okay. So do you have any legal capacity? Let's say next year, a critical provider says help for whatever reason. I have no cash, days on hand, et cetera. I can't pay my bills and the 2 million's already spent. What, as a Medicaid commissioner, do you have any capacity to intervene in situations like that?
I mean, we could look at like cash advancements that they would draw down against.
Against potential?
Yeah.
Could you do something and come in for BAA?
I would have to see.
Yeah, there's a critical provider in this community, and if it goes away, we can't, it's
Exactly, yeah.
too big to fail or too little to survive. Thank you.
Those conversations also typically involve a full representation from the Agency of Human Services.
Yep.
So in the
Team
event that
Decision.
this department doesn't have a funding
Sole
source
authority or funding.
identified, there is at least a review of other potential options.
Okay, thank you.
Yes, I've been looking at the report that you linked to, and I had heard earlier this in a session that Valley Vistas, which was, I think that their situation prompted the ask for $10 million last year, that you are still in negotiations with them, and that they have not agreed to an essential request that they remain in the state for a certain number of years as a result of getting the funding. And I think that it says that they have not engaged with you since the end of October. So I just am wondering what this means about, this was such an emergency last year. Money has not been awarded. Now it's a year later, and I'm just wondering whether whether Valley Vista is in decent shape, or you have concerns about where they are right now. And second, will this money revert to the emergency fund if by what date do you imagine making a determination about this request?
Yeah, I will say the negotiations with Valley Vista have been handled at the agency level. And so they have not been able to come to an agreement between the terms of what they're at, what's being asked of them, and part of that is to look at the whole system and what about the role that Valley Vista is playing. And so there have been some kind of negotiations back and forth between the agency and Valley Vista. And I think we're just waiting to hear back from the agency of whether or not what the next steps are. But we have reserved we reserved 2.7 million for them because that is their request. I think it's just about the negotiation of the terms of the agreement.
I mean, I think you make a good point that we don't want to give money to organizations that are going to close and move out of state. So I really hope that maybe we should put this in there too, if it isn't, there's some sort of residency requirement. We do this for loans for professions when we send people to nursing school and things like that. And it would be unconscionable not to do something similar with giving these places, making that a requirement.
Well, and I'm just confused because last year when this was presented to us, this $10 million emergency fund, it was presented really, I mean, it was known, but not probably articulated, in oral testimony, that Valley Vista was one of the organizations that was in dire need of this. And it's now been a year. And how dire was that need? I guess my question is, and I'm raising it just as a question since we have a member of the healthcare committee here, and I have raised it with Human Services. So.
Yeah, I mean, also to answer your point, like part of the application process is to submit a sustainability plan. So we do look at making sure that they do not plan. And so that's kind of where I think the tension lies, is ensuring that they can meet those agreements and whether they agree to that. But in other kind of provider situations, their sustainability plan, they have actually showed, other kind of providers have shown in their sustainability plan that they are committed to staying where they are and kind of they have a plan to make sure that they're not asking for more money next year or the following year.
So the chart we see is last year's disbursements?
But this current year, yes. Yeah. Yeah.
I'm just curious on the stabilization plan. Is there then follow-up between DIVA and the organization 3, 6, 9, 12 months out, some time frame to see where they are on that stabilization plan?
Yes. So for instance, there's one health center that a federally qualified health center that is scheduled to kind of meet with the agency and DIVA in March. And so we'll go over those kind of where they are in that plan, what they have been doing, and kind of looking forward of how successful they are in achieving those benchmarks that have been laid out.
Dave, you look like you're.
Well, my thinking is tainted from what's happening at the national level. I want to be diplomatic, I hope, but I don't know if we put any guiding language around the stabilization monies. People are only human, and I'm sure it wouldn't be this way in Vermont, but sometimes I don't want a room full of executives, boy, Mike's been a real pain in our, yada, yada, yada. And decisions made on personalities as opposed to, boy, here's a region of the state that if we lose ABC provider, there's a real hole for access. That kind of thing. And maybe I shouldn't worry about that in Vermont, but when I hear of these decisions being made, at the executive level, what criteria do you use?
Right.
And they're all good people. I bet their hearts are right, but sometimes it's good to put it in writing so they can go back to that and say, we've got 5 of these other residential care homes here. We hate to lose ABC, but there are others and they're not completely full, as opposed to, wow, here's a designated agency. We've got a problem. There's no mental health services. So can I noodle on that? And
Noodle on that, and I'm wondering if that's something that the House Healthcare Committee will be taking up. So Lori's nodding her head.
we're giving them a lot. No.
Yeah.
Oh, what I made today.
You can't.
I love it, I love it.
Can I make a comment?
Go ahead.
So we actually do lay out the criteria and that we have used in the report.
Thank you.
Okay. All right, I think we're done with this page for the moment.
All right. So ending on a positive note, key accomplishments. I think this year has been, if you look at it, it's been a little topsy-turvy. We started with good news of we were 3rd in the nation and we had a great healthcare coverage. And then we had things happen on our federal landscape that were not so good. But DIVA has weathered the storm and I am extremely excited and I could not be more thrilled to have the team that I have in place at DIVA to kind of help us there. Kind of 3, or that's not 3, I said 3, but 5 things, 5 areas of where I want to kind of point your attention to is kind of the marketplace ability. We completed open enrollment for the qualified health coverage for 2026 with solid enrollment despite the expiration of the enhanced federal premium assistance. And so that was kind of big for us. We looked at, going back to our conversation, we distributed provider stabilization fund to protect access to care in areas and looking at provider insolvency. Another thing was around payment reform and system transition. We successfully managed the sunsetting of the ACO and launched the voluntary hospital global budget model for 2026, where we secured 6 commitments from Vermont hospitals, ensuring that a population-based payment reform continued in the state. We expanded eligibility thresholds for Medicare Savings Program to improve access. And then we also kind of instituted a comprehensive refresh of the strategic priorities for DIVA and how we will guide our decision-making and going in the future years. So just want to, and then also, when you have time, or if you have time, the annual report kind of lays out more detail on our accomplishments there.
Thank you. So I'm just sort of in my head trying to think about new initiatives for this year seem to be related to eligibility, which is a requirement. Any other big events happening that are new this year?
So I think we have our hands full with HR1 application.
So you have 12 positions. Can you talk a little bit more about why you need 12 and what they're going to do?
And I'll turn that over to Deputy Commissioner Addy.
Okay.
Sure, I can pull up the list, but essentially it's 8 eligibility workers. So I mentioned before that we made a projection based on the 30% increase in our workload. So this represents essentially kind of a 30% increase in our frontline eligibility workers that process the applications and do the eligibility redeterminations to accommodate that increased work from HR1. There are 2 positions. One position is for the noticing team to accommodate the extreme increase in noticing based on the kind of doubling of the renewal sequence and cadence, for the new adult population. There's a position for IT testing for the significant system changes that need to go in. And then 2 positions to do with communications and outreach to support that, very fundamental part of the implementation work.
And does this go January of 27 that everything goes into effect?
Yep, that's right.
But you're assuming the 12 people for a full 12 months? Or did you?
We will hire them this summer if it gets approved and onboard them. We usually do training kind of late summer so that because the process of the redeterminations and the renewals has to start ahead of January 1st in order to comply with the deadline.
Right. Okay. That's helpful. Thank you.
Mm-hmm.
Questions on that or? Any other questions for Diva? Dave, go ahead.
Well, do you believe if we had a more robust primary care throughout the state, that the number of non-emergent emergency room visits, which I think Dartmouth students said are like 30 to 35% of our emergency room visits are not emergencies. Do you think it could be lowered? Is that a good investment? If somebody said, Diva, we want to lower the cost of healthcare spending in Vermont, what do you think of this idea? Or do you have others?
Oh, so we're getting very philosophical here. No, I do think there is a need for an investment in primary care. And I think that's what the Rural Health Transformation Fund does. I think there's also a need to kind of handle like care coordination and case management as well. And so I think there is a lot of things that, while primary care is important, I think it's important to kind of look at the population in total and see where the needs are and where there are opportunities to control that. But if we're looking at kind of how do you reduce ED visits, I think one of the things is having a robust primary care and care coordination system.
Thank you.
Okay.
It seemed to me like if this rural health transformation comes in, it'd be a good opportunity to collect data to see whether or not any of those activities actually decrease emergency room visits. But if you don't think about collecting the data ahead of time, you won't, after the fact, won't work.
So I'm looking at your ups and downs, and there's a couple of things I just want a little clarification on the lines. In B306, you have vacancy turnover savings of almost 700,000 general fund and another 715 federal funds for $1.5 million. Are those positions that you're not hiring? How many positions are we talking about when you're using that to balance your budget?
I would have to go back and look, but we are hiring. I think there's a number of new kind of vacancies that we did not foresee coming. And so those are kind of open positions. And I think where we use that 3%, I think what we're seeing now is we're closer, the vacancy rate is higher about.
I wanna say it's 7.
And is this, because there is turnover and that's how you're creating the savings between hires when somebody leaves and somebody comes, there's.
We've had quite a number of folks leave for various reasons at RTO, so we're actively trying to help.
So RTO being returned to office, and you've had some people leave as a result of that.
Correct.
Do you have a sense of how many?
I can say for my business office, we have 2 folks in our analytics team. This is previously a team of 4. Now it's a team of 2 that we will start actively hiring for. But in the business office specifically, we are 15 and had 2 or 3 leave that we have
For that particular.
for that particular unit. Yeah, I can't speak for the rest of the units, but for my unit, that's.
Yes, so return to office is impacting some of the work. Yeah. That would be good to get some more information about that. And then the other one, we sort of talked about it, except I don't really understand it, sorry, is in B307. The applied behavior analysis coding corrections is a decrease of 1.4 million. Just help me understand in plain English what that means.
Yeah, so in our applied behavioral health benefit, which is a benefit for children with autism disorder, we have taken a look at, there is a need to look at our concurrent billing practices. This comes from the federal kind of compliance lens that they were looking that there were in their audits, in the federal audit, they were really looking at states with this benefit and whether they had plans. And what we were seeing is a high number kind of clawback from the feds on that. And it was and we've viewed this as a risk. And so part of this is to kind of we now have starting January 1st, is a concurrent billing policy. And because of that, we're no longer allowing the billing of 2 codes at the same time. And we will see a reduction in spend there.
So again, this is not my wheelhouse. So does that mean that families who have, let's see, I heard you say children with autism, will they not get the same services that they used to get, or will they have to pay more money as a result of that?
So neither one of those. So what we're saying is that you're paying for the patient's time and not for having 2 providers at the same time of the billing. So what we're saying, so the patients are expected to have the same level of service moving forward. We're just not allowing the providers to bill 2 codes at the same time. So it's on a provider issue. They're no longer allowed to pay, yes, and that's the reason why you see a reduction.
Someone's getting paid.
Yes.
Yeah, so Wayne and then Dave.
So essentially, double billing.
Yes.
Well,
Not really double billing. No.
It's 2.
No, it's concurrent billing of where one billing was a supervisee and the other one was a supervisor. And so we're no longer allowing that billing to happen. So we're no longer paying for the the license.
I think I've heard about this. So if you're in training and you need a supervisor, there's a cost to the supervisor training the trainee, and now they can't bill, the supervisor doesn't get paid for supervising the trainee.
During the same visit, yes, that's correct.
So Dave,
now, New Hampshire did this, but then I was told New Hampshire pulled it back. Have you heard any more on the New Hampshire experience?
I would have to get back with our Medicaid policy.
Would you, because when we met in December, as a small group, appreciate your help during that. We were told that New Hampshire was doing the same thing Vermont is doing, but then reversed it. So we said, well, look,
yeah,
good for New Hampshire. And my understanding is also, correct me, Commissioner, if I'm wrong. When the hands-on worker is working with Dave in the school who has autism, concurrently on the same time, the supervisor and the hands-on worker might be communicating. and saying, I'm trying these approaches, what should I do differently? So it's happening at the same time. My question is though, could the rate be increased for the hands-on worker, the therapy person, in such a way so that it's inflated to cover the ongoing supervision that they need?
There is a possibility, and I also want to say that there is a rate study for the ABA benefit that it's due. Yeah,
So that's possible.
so it's possible.
Wayne, you look like you want to say something.
I don't know if I should. Obviously, I mean, back to the service is being provided to someone, and you got another person there that's being paid at the same time. But the billings should be for what's being received by the person. The training is something else.
Yeah, I think that requires a little more digging into, Lori.
We have this on our agenda in the policy committee tomorrow.
Okay. Dave may be spending a lot of time in your
He
committee
might.
tomorrow. Something, that's why we have the healthcare committees. We don't always understand it, and that's why I ask crazy questions, because I really don't understand a lot of the stuff. Okay, was there anything else that anybody wanted to ask of Diva while they're here with us? I really appreciate you all coming in. More to come from the healthcare committee. Dave is our liaison. Thank goodness, Dave, you're the liaison. And we'll funnel questions to him, and then the healthcare committee will also know a lot more. So we really appreciate your time. Thank you very much. So committee, you have a few minutes to work on your budget areas or whatever. And then we're back at 1 o'clock with the Agency of Education, and the Secretary of the Agency of Education is actually going to come into our committee this time. So we'll see you all at 1.